for her. So she has her slides up here. Is she coming? Okay, well, if Bridget isn't ready yet, our speaker after that is Andrea. Andrea, you're fine? Andrea Rosenhaft is a licensed social worker, has been working as a licensed clinical social worker in New York City for over 20 years. She is recovered from borderline personality disorder, BPD, anorexia, and major depressive disorder. Andrea is a published writer and blogger, primarily on the topic of mental health and recovery. Andrea is founder of the mental health advocacy and awareness organization, Be Well, Be Strong. And I'm amazed to see you in person. I didn't know it was you. I heard about that. So thank you. It's wonderful. And she also rescued her dog, and what's the dog's name?
Shelby.
Shelby, 2 years ago from Mississippi. And thank you for that.
Thank you. Thank you. A little handicap here. Okay, that's okay. Yeah, that'll work.
Is the mic's gonna work?
Yeah, it just takes a second. That's not, oh.
She's got more power than she knows.
Technical problems, it's a problem.
Jello. Make me something.
Ask me if I know my password. What if I have my computer with me?
Yeah. It's very complicated, so I can't access it. It's not a shared thing. Oh.
Mac.
Maybe you don't have that.
Or you don't have that adapter? Wait a second.
It's the same.
I just gave him the flash drive. It's on the flash drive, yeah. I can move my password.
Over there, I just touched on the shareable link. So what you're saying was like launch your account.
So what do you want me to do?
As long as we just have a few minutes here, I guess. What did you learn this morning from the presentations? Did you learn anything? Anything stick out in your mind? And I was kind of surprised that there's no infections. And anything else stick up in your minds from presentations today? Also, it's people are going to do what they're going to do, right? And the harm reduction really does make a difference. Just expecting the people to go to zero on substance abuse or anything, it's a too high expectation for any human. And I was gonna say this before we go to lunch, but I work in mental health, and we've just seen a lot of trauma-inducing pictures up here today. So I just wanna remind you during lunch, if you can't, take care of yourselves. Because it is traumatic to see this, and we also just saw how many pictures of people who died from COVID. That's hard to see. So take care of yourselves. And I know it's gonna sound a little crazy. So there's a new thing, it's new and old. So when animals actually go into shock and they encounter a traumatic event, do you know what they do? They shake. They actually shake it out. So they stop, they get surprised, shocked, and then they shake it all out because it's now, there's embodied psychology, things like that. It gets stored in our bodies. Trauma gets stored. So one way to get it out is actually dance and music. And tomorrow we're going to have a presentation on music. So we'll listen to that, vibrations. So I encourage you during lunch, you don't have to do it here, dance or shake it out. But seriously, because with trauma, we watch the news, we do this, and we learn to, oh, it's just okay. Well, no, in human hearts, it's not just okay. It's not just okay. We can also learn different ways to let it go. And it's important, because Mary, what you're talking about this morning, all these human deaths that happen that could have been prevented, that's extremely important and extremely traumatic to think about it and go through it. How are we doing? No, but, and actually what I'll be talking about later this afternoon has to do with trauma-informed care and how to work with it from a trauma-informed lens. But I like to shift it because why are we always looking at deficits? What are the positive? What's healing-informed care? What really works? So are we up? Doing okay?
Almost.
Good. Okay, great. Andrew's going to speak right now. So let's think about shifting the view from deficit thinking to positive thinking. We actually have more than enough of the world to do what we all need to do. We have abundance here, and Mary's ready. Andrew's ready to go. And hey, how are you doing?
Good.
We're okay.
I think so.
Great.
Yeah.
Excellent.
Yeah, because I've got to introduce. Yeah. Wow. Okay, thank you. Thank you very much. So today I'm going to talk about how layering the treatments of dialectical behavior therapy and transference focused psychotherapy help me fully recover from borderline personality disorder. Oh, thank you. So I'm recovered from anorexia, major depressive disorder, and borderline personality disorder. I've been working as a licensed clinical social worker for over 20 years. 6 of those include working at a major leading healthcare managed care organization, and for the last 3 months, I've been working as a telehealth psychiatric social worker. Thank you. So this is the definition of BPD, and BPD is a disorder that typically happens in the context of relationships. BPD carries a significant stigma within the psychiatric community. This is a Time magazine cover, circa 2009. You can see the subhead, borderline personality, the disorder the doctors fear most. Thank you. This is a excerpt from the introduction from the anthology, Beyond Borderline, True Stories of Recovery from Borderline Personality Disorder. This is written by the late Dr. Perry Hoffman, who was the co-founder of the organization National Education Alliance for Borderline Personality Disorder. So DBT is one of the evidence-based treatments for BPD in which individuals learn coping skills for seemingly intolerable emotions and situations. And the 4 modules that make up DBT, it's like alphabet soup. It's like mindfulness, emotion regulation, interpersonal effectiveness, and stress tolerance. So there's been many studies on the efficacy of DBT. This study So this finding is from a 2-year randomized controlled trial and follow-up of DBT versus therapy by experts for suicidal behaviors and borderline personality disorder. Okay, thank you. And this study was one of the first studies for DBT, and it's from cognitive behavioral treatment of chronically parasuicidal borderline patients. So, from my life, following my second suicide attempt, I was diagnosed with BPD and sent to a long-term unit at a hospital up in Westchester. I was 29 years old, and on the unit, there was a really strong sense of community. I felt safe for the first time in my life. I didn't feel like a freak. No one questioned the scars on my arms and the fact that we all had multiple suicide attempts. The professionals, the psychiatric professionals on the unit wanted to be there. They were part of a minority of psychiatric professionals that wanted to treat patients with BPD. So this is what intensive DBT treatment looked like back then. We basically lived, ate, and breathed DBT. Okay. So I was devastated after 10 months when the psychiatrist told me I had to leave. My insurance wouldn't pay anymore. Can you go back one? Thank you. So I went to a discharge to a BPD Day Program, which was run by the same hospital that has the inpatient unit, where I stayed for 18 months. A lot of the staff from the inpatient unit went over to the day program. So I stayed there for 18 months, and I continued with my therapist there, and I saw her in her private practice. And I earned my MSW in 2000. So in 2005, I just stopped all my medication. I quit therapy, which surprised me because I'd always been like the quintessential good girl. I think I realized that therapy had been stalled for quite a while. Without my medication and without therapy, I spiraled down into a suicidal depression, and a group of therapists I'd been seeing referred me to a psychiatrist she knew that specialized in TFP, or transference focused psychotherapy. And the original appointment was only supposed to be for a medication consultation. So, unlike DBT, which is focused in the here and now, TFP is a psychodynamic treatment which goes back into the past and explores prior relationships and how they may have affected you. The premise is the dysfunctional patterns created in potentially all relationships is recreated in the relationship formed with the therapist. Okay, thank you. All TFP therapies start off with the patient seeing the therapist twice a week. And they start off with the patient agreeing to a contract. All the contracts are individualized, depending on the patient. However, when one starts TFP, the contracts look something like this. So this was my contract. Since I was suffering from an eating disorder, there was something about my weight. I was actively cutting myself, and I was chronically suicidal. So this is a quote from Dr. Otto Kruger, the father of TFP. The key here is reflection and integration, which I'll talk more about later. Okay. So it took me years to develop trust with my therapist. I was terrified of being laughed at and or rejected for venturing an idea or an opinion. I remained silent in therapy for many years, which actually extended the course of the therapy. Okay. I also had the delusion that my thoughts and subsequently my words had the power to hurt or even kill my therapist. The last criteria for BPD is transient stress-related paranoid ideation or severe dissociative symptoms. As an example, in 2010, when that volcano in Iceland erupted, I won't even try to pronounce the name, it sent ash all over Europe. My therapist is from Europe, so she had planned a vacation going home, and plane couldn't land. And I told her that I thought I had made the volcano erupt because I didn't want her to go home. So I needed to know that she wouldn't judge me, but her compassion, her facial expression, and her words just exuded nothing but compassion. Next slide. So the therapeutic alliance is the best predictor of a successful therapy outcome, and after she was my fourth major therapist. The other ones were just like minor therapists, and I have found the right connection with Dr. L. Let me just say, next slide, please. So in TFP, working on the relationship is critical, and it's important to realize that the relationships don't have to be with living people. They can be with people who have passed, as long as the relationships were important to you. So as much as I love my mother, she had already passed when I started working with Dr. L, and she was my anchor. It was a very painful realization that my relationship with her, with whom I had been enmeshed with her, was holding me back. And when she passed, I was able to make some progress. Thank you. My relationship with my father was a different story. He was still living, and we had a conflicted relationship. He was an alcoholic, and I never heard him say I was good enough, and I was always chasing my need to please him. Thank you. I didn't expect to go into a tailspin, though, when he passed away. I was terrified that I'd blown it with Dr. L, if you remember the contract. That's the one, the item about suicide, but she thankfully agreed to give me a second chance. And the intensity of our work increased tenfold after my discharge from the psychiatric hospital. I was finally able to acknowledge the anger I'd been holding in my whole life, and the rage that had bottled up without resorting to self-destructive behaviors. Thank you. So many studies have been conducted on the efficacy of TFP as well. Okay, thank you. So this one is evaluating 3 treatments for borderline personality disorder, a multi-wave study. 3 treatments are TFP, DBT, and supportive psychotherapy. Thank you. And this one is transference-focused psychotherapy versus treatment by community psychotherapists for borderline personality disorder, a randomized controlled trial. Okay, thank you. So these are some techniques that TFP's trained therapists typically use within the context of the therapy. Excuse me. The first one is interpretation. So the interpretation really solves a puzzle within the patient's psyche. The key to the puzzle unlocks the reason the psyche continues to remain fragmented. So one interpretation that Dr. L made with me is when I was just starting to recover from anorexia, and I was working as a social worker in a small outpatient clinic in Queens, and I was given the task of going through some of the other therapist charts in preparation for an audit to make sure they were complete. And when I was actively anorexic, I used to feel superior because I could restrict my calories to like 200-300 a day and lose weight rapidly. And in going over these charts, I also was feeling superior because I was finding errors. And Dr. L noted the body language and my nonverbal communication and how I was describing this. And she made the connection between my need to feel superior from the anorexia was transferring over to my work at the clinic. Can you do that? And she made me aware of how important this feeling of being superior was to me. And we went on to explore why that was and resolve this conflict, but the process in itself actually took years. And the goal was to gain insight into why feeling superior seemed to be so important to me. Okay, thank you. And another TFP technique is confrontation. And despite its name, thank you. She did so calmly and matter-of-factly, and she used it sparingly, but when it was necessary. So one example is this aforementioned silences. I was maintaining them due to the belief that I needed to pause and gather my thoughts, because when I was dealing with my father, who was emotionally and verbally abusive, I needed to stop and think what I was going to say to minimize his emotionally abusive torrent back to me. And Dr. L said to me, bullshit, basically. She believes when I pause, can you go next slide? Thank you. I was putting the reins on my anger, especially towards her, which I was terrified to express because I was afraid of losing her. Unconsciously, I believed if I expressed anger towards her, she would abandon me. And this was an interpretation she made that she confronted me with, that she did not believe, basically the reason that I was maintaining silence all these years. Okay. So this is a paper that Dr. Kernberg published. He's the father of TFP. He's in his 80s, just as spry as ever. And in it, he identified 4 major areas of present functioning to be assessed in the initial diagnostic evaluation. Next slide. Thank you. So these allow the therapist to understand the patient better outside the therapist's office. Can you go to the next slide? Thank you. So these give the therapist a more comprehensive picture. Next slide. And these give the therapist valuable insight into the split down the way in which the patient presents in her life and versus what she says are her identified goals. Okay. So Dr. Mary Zanarini out of McLean Hospital did a 10-year longitudinal study. And what she found that although 85% of patients with BPD remitted in terms of self-harm and chronic suicidality, there was a drop-off when it came to social functioning and ability to hold a full-time job, and that drop-off went down to about 50 to 60%. So, all in all, I was in TFP for about 11 years with Dr. L, a long time. And my 11 years with her gave me the opportunity to improve my life dramatically across these four areas. So I've been working as a full-time as a licensed clinical social worker for over 20 years. When I entered TFP, I was naive sexually. My father, as an alcoholic, didn't give me the role model I needed for men to be able to interact with men safely and assuredly. But, go back a second, sorry, thanks. Although my feeling of safety with her enabled me to talk about sex for the first time. And I was able to come of age sexually when I was seeing her. My parents have both gone, but my brother is my best friend, and we are really close. I actually walked him down the aisle at his wedding in 2018. And I have friends from my writing groups, from my entrepreneurial groups, from previous jobs, just a wide range of close friends among a lot of interests. And my writing is a passion of mine. It keeps me sane. And I've been published in literary journals, in anthologies, and I write about mental health and recovery to let others know that recovery is possible. So termination in TFP, here's that word integration again, and what integration looks like is, I knew that I was ready to start terminating when Dr. L went on vacation, and I would no longer freak out and need to see her recovering psychiatrist when I actually looked forward to it for the break from the intensity of the work together and the financial break. So at the end of 2015, after 10 years, I told her I wanted to spend the next year terminating. This is from someone who thought they'd never be able to function without a therapist. Wow. So I just wanted to say that the foundation of DBT skills that I built on the long-term unit and thereafter was instrumental in helping me tolerate the intensity of the work we did in TFP. because, the painful, work that we did, the emotions uncovered and the discoveries, were all tolerable because I was able to use my foundation of DBT skills without resorting to cutting and other self-harmful behaviors. Okay. So thank you. Is there any questions? Yeah.
It's good to have the mic.
How does your personal experience influence what you do today as a clinical social worker? All these wonderful, in your recovery.
So I'm really able to empathize closely with patients. I actually like working with people with BPD, because I know that they're suffering, that they're not manipulative or attention seeking. Like the stigma, like many of the stigmas, perpetuates. I work with eating disorder patients because I can basically know what they're going through, major depression. I know what that dark abyss is like. So I don't usually self-disclose. I don't know if they Google me. I haven't had anybody tell me that they have. If they do, they don't tell me. I don't mind. I think it makes for, if they know I've gone through what they're going through, it gives them a sense of security that their therapist knows where they've been. Any other questions? Okay, thank you.
Actually, another question too. Can you talk about really the differences between DBT, which is dialectical behavioral therapy, and DBT, the other one? Because actually dialectical behavioral therapy was founded by Marshall Linehan at the University of Washington in Seattle. It's actually based on Buddhism and the principles out of Buddhism. And so can you talk about the differences that how those two helped you in different ways?
So, in DBT is a very here and now treatment, and it's based on those 4 modules that I mentioned before, and you learn coping skills. So, but one of my favorite coping skills is radical acceptance, which you fully and wholly accept the present without judgment, and it's not about forgetting and forgiving. But like, for instance, I had a stroke in 2018, so I had cognitive deficits. So every day I practice radical acceptance to accept the fact that my brain will never be the same. So TFP, the example I gave about my mother. So I go back and into the relationship I had with my mother, which was very enmeshed. And in DBT, you don't really go back and look at relationships.
Okay.
For instance.
Gosh, you learned so much. And also your blog. How do we find your blog and what you're doing online?
My website is just the letter B, WELL, Be Strong, just the letter BeStrong.com. And my blog is called From Both Sides of the Couch, and it's on the website of Psychiatry Today.
Wow. Thank you. Thank you, Andrea. So we're going to have a break now, and for lunch break. What time is lunch? We're trying to get it catered earlier. 12:30 will be lunch in the room.
Yeah. So the lunch is at 12:30 in the same room that you had breakfast. One of the speaker, Bridget Tan, I think she stepped out, and we are expecting her to be back in 10 minutes. If she's back, she will continue the conversation. Otherwise, we'll have a break until then.
Till 12:30.
Yeah. 12:30.
And then the afternoon session will start at 1 o'clock, is that?
We will make it
1:45?
1:45,
1:45, right?
1:50.
1:45? 1:30?
1:30. Yeah, 1:30.
Okay, so we'll start the afternoon session at 1:30, okay? A little bit earlier. So, okay, lunch. That's fine. Or do you want a longer break? We have it scheduled at 1:45. What will work for you? 1:30?
Yeah, 1:30 is good. Let's recap that. It should be, lunch should be about 12:30. It should be. Thank you.
Oh, now? Is everybody? Okay,
He'd like a small group photo. So Andrea, before you leave, I'm going, up here? Where do you want the group photo? Oh, back there by the screen. Okay, let's take a group photo. Take one tomorrow too, right?